Hi guys, Chris Duquemin, body engineer. Today I'd like to talk a little bit about intracranial hypertension and the ever-increasing numbers that are being diagnosed with children. I believe there could be a very straightforward answer as to why this is occurring, and for me it's trauma, forces applied to the young baby during the delivery process. I think it's as straightforward as that. What we're seeing statistically is an increasing amount of intervention during the birth process, but we're also seeing proportionately an increase in the number of children that go on to develop special educational needs, for example. Now, I want to make it quite clear before I go any further, I am not here to start talking to midwives and doctors and saying this is how you should deliver babies. No, because the intervention that we're talking about often saves lives. So this isn't a case of that at all. Doctors, midwives, you guys do an incredible job. I would have lost one of my own children if it wasn't for you guys many years ago. So, I've got the greatest respect for the work you do. However, the forces applied to the human body during the delivery process are quite significant. I don't think that anyone would argue that. So what I found statistically over the years, the reason I'm doing this short video, is that over 90% of all the children that I treat, children and young adults with a wide variety of chronic conditions, including IH, almost without exception, when we talk with the parents, there was some trauma during the delivery process. We had a ventouse, forceps, cesarean, cord round the neck, breech, early rapid delivery. Something happened that mechanically left a force, a pressure on the central nervous system. So from that young person's very first external breath from mum, we have a compromised central nervous system. The master computer is already having to adapt to the fact that it's compromised. So statistically, as I say, it's over 90%, and what I'm interested in doing, if any other healthcare professionals are out there and this is resonating with you, we're starting to gather data now to prove that link, because ultimately from an engineering perspective, which is where I'm coming from, it's all about prevention. It's about being proactive and doing something to prevent something from occurring, instead of waiting a few years down the road when we get symptoms and we then try and fit someone into a pigeonhole to give them a treatment program. No, let's get in there early. Irrespective of the birth method, if we lived in nirvana, if we lived in this idyllic world, for me, all babies would be treated. Let's take it a stage further. I would treat, if I had my kids again now, knowing what I know, I would treat all youngsters at birth just to make sure that there's no pressure on that developing central nervous system. I would also treat them every 6 months up to the age of 3. I personally believe if by the age of 3, there's no physical pressure on that young person's developing nervous system, we've got a fantastic foundation for a healthy young adult and adult later on in life. Yeah, so it's about prevention and being proactive. So how does this tie in with intracranial hypertension? Well, let's go back to basic mechanics, yeah? During the birth process, again, it's not rocket science. You picture a baby this big coming through an opening that's significantly smaller. We've all been subjected to these forces and pressures during the birth process. So it's not uncommon that the neck becomes displaced with the base of the skull. The skull doesn't sit on top of the atlas axis joint properly. What that does, if you've seen my previous videos, it compresses the jugular foramina, the little opening at the base of the skull that affords pathway for the blood supply draining back to the heart. There's one on either side, and also 3 cranial nerves, 9, 10 and 11. So cranial nerve 10 is our vagus nerve, our fight or flight nerve. There's 2 branches, the dorsal and the ventral vagus. And we also have our accessory nerve, and the accessory nerve is probably one of the most significant ones from a structural perspective, because as we've mentioned previously, what it does, these are 2 big rubber bands that are connected from the top of the collarbone and all the way across the shoulder and down to the mid-back. And anatomically, they connect to the base of the ear and the base of the skull. So we know, if you've seen the previous work that I've posted, that we have the central nervous system, the brain and the spinal cord is a bit like the master computer controlling every function in the body. And it effectively floats inside a fluid-filled balloon. So this balloon molds to the inside of the skull and travels right the way through to the back. So again, common sense dictates that if we've got rubber bands pulling on the skull plates, it's going to prevent the lateral expansion of the plates that should occur when the cerebrospinal fluid is produced, roughly rhythmically every 3 to 4 seconds. So not only does it affect the production, but it also affects the reabsorption, because when you squeeze a balloon and you maintain a constant force, you're applying a pressure which is abnormal to the system. So the system's pressurized mechanics cannot adapt because there's an artificial and external influence. And that external influence with the youngsters that we see, usually, unless we've been involved in an obvious trauma like a car crash, it usually comes from birth. So really what we're saying here, guys, is if you have a child with intracranial hypertension, first do no harm. We need to make an accurate diagnosis to rule out the fact that there could be a mechanical restriction. And the reason I'm doing this video is because the parents that I've spoken to date, almost without exception, we have, when we look at that person's history, yes, it was a Ventouse, it was a forceps, it was an emergency cesarean. There was some kind of trauma that that young person's nervous system couldn't cope with. Bodies are very resilient. We go through a lot of trauma on a day-to-day basis, and most of the time our body can resolve it. But quite often, if it's mechanical, the body says, hey, I can't sort this out. So what does it do? It has to learn to live and compensate and adapt around the underlying pressure. So again, very, very simple diagnostic check that we can do with your children to ascertain whether or not there is a mechanical component to the intracranial hypertension. Because here's two reasons straight away why birth trauma, the forces during birth that are unresolved, could lead to intracranial hypertension. These are very, very straightforward points. This is not rocket science. This is accepted medical knowledge and basic physics. The body doesn't develop structurally until we're about 18 to 19. That's when the skeleton is set in stone. So imagine having a vice and there's something lightly clamped inside the vice, and that vice is a pressure left over from the birth process. The vice doesn't change, the pressure remains constant, but what's in the vice, which is the body, proportionally the pressures increase as the body continues to grow. So over time, the symptoms will get worse and worse and worse because the pressures are proportionately increasing with time. So what was a baby that didn't latch properly, didn't feed, didn't settle, wasn't comfortable, begins to manifest other symptoms later on in life. And unfortunately, these symptoms are often deemed to be independent of each other and they're treated in isolation. Nobody looks for a common root cause. We're engineers, right? This is what we want to do. So to identify if your child possibly has a mechanical restriction, we just do one simple check. We check the uvula in the roof of the mouth, ask your child to open up as wide as they can and just go, ah, ah, ah. If the uvula deviates to one side or the roof of the mouth does not lift symmetrically on both sides, that's clinical confirmation that the ventral vagus nerve is jammed. Another quick check would be to lightly, very lightly squeeze the shoulders. I'll guarantee you'll find that one side is tighter than the other, or one shoulder will be elevated if you look at that person in a relaxed state, because the elastic bands are tight on that side and preventing the skull plates from widening. So again, several other mechanical reasons why we might have intracranial hypertension. One, because the skull plates are not widening. Two, because if the jugular foraminor is compressed, it's going to have a negative influence on the blood pressure, the natural venous blood supply draining back to the heart from the brain. So common sense dictates if the blood supply draining up is not draining back down in the same volume, we will always have a proportionate increase in pressure. So we have cranial plate distortion, we have vascular pressure, and of course all of this is just monitored with a spinal tap looking at the CSF. No one's asking the question, yes, we have CSF increase in pressure, but why? Why do we have this pressure? This is what engineers do. This is the questions we ask. So let's look for the obvious things first, guys. If your child has intracranial hypertension, do those two checks. If they fail one, they will fail the other, I'll guarantee it. And then you know that before we start going down the road of shunts, etc., we need to rule out any pathology. That's very important. We need to make sure these guys are getting the scans, the x-rays, to rule out anything sinister, like tumours, cancers. That's a different ballgame. So we use the modern medicine toolbox diagnostically. But once we've ruled that out, before we start looking at shunts, etc., we should be doing the obvious. We should be looking for the mechanical influence that could be causing the intracranial hypertension. This is the success that we've had so far, is just doing the simple things. So please, if you have any questions, get in touch. I hope that makes sense, but just look for the deviated uvula or the fact that the roof of the mouth is not lifting symmetrically. Just a quick one on that. We need to sort of make and break the circuit. So we need to go ah, 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 as opposed to ah. A long drawn out ah doesn't make or break the circuit, so it's difficult to see. So ah, ah, ah gives you that clinical confirmation that the roof of the mouth is indeed lifting symmetrically. Usually you'll only see one side lift. In extreme cases, both sides will be jammed. You won't see the roof of the mouth lift at all. Okay, that will give you clinical confirmation, again with light shoulder touch that there's a mechanical component to the child's structure. There's an imbalance there that we need to address first. Okay, so please, any questions, get in touch, and I hope that's made some sense. All right, take good care.